Hello everyone. We're going to discuss NAC OSCE examination, and we're going to start with the orientation. Um, NAC OSCE exam is conducted by Medical Council of Canada. It is a requirement for internationally trained or graduated medical doctors who want to do residency in Canada. Without these exams, you cannot apply for residency in any of the provinces. To the best of my knowledge, I know that none of provinces accept your application without a NAC OSCE score. Therefore, you have to take this before you start applying for residency. And the exam is designed to identify those IMGs who are able to practice in Canada safely and effectively without harming anyone. Most of IMGs taking the exam, they're already doctors in their home country, but Canada wants to know if they are suitable to practice medicine in Canada. That's basically the idea behind the NAC OSCE examination. Now, like I said, NAC OSCE exam, it is a one-day exam, finishes in half day, takes half day. You have 11 minutes of a station and 12 stations. Out of the 12 stations, you have 10 stations that are considered for your final score, and 2 stations are pilot stations that do not affect your score. Between these 12 stations, you get 3 stations that are basically breaks. You don't do any station, you just sit outside. You can use the washroom if you need to. You can take a water break. You can ask the staff there to give you water to drink if you're thirsty, or you can go to the washroom, wash up your face, get fresh, come back. I already said NAC OSCE is a requirement for COMS application, and it is competency based. The idea is that they want to see how you do in real-time clinical scenarios. If a patient comes to you in your real life, how would you manage them? How would you interact with that patient? How would you address their concerns? How would you treat them? And they would just want to make sure that you're able to talk to the patients with empathy, address their concerns professionally, and manage their symptoms or their conditions safely without causing harm. This is a quality benchmark. This ensures that IMGs who are entering residency in Canada, they have a baseline for their safety, and they are able to communicate professionally with the patients and show empathy as appropriate. And most residency programs, they will use your score as a filter for whether they want to interview you or not. So make sure you score as good as you can. Passing grade, so the exam score is from 500 to 700, and the passing grade is 577, which comes to, if you are going to calculate it in percentages, it's not a percentage based as MCC states, but if you were to say, oh, how many percent of the total score should I get? It's about 83%. And that's a tough score to get. Still, some programs will not consider your application if you have score less than 630 or 640, depending on program. The programs with the highest requirements are usually surgery-based programs, psychiatry, internal medicine. These are the programs that require a really good score in NAC OSCE. So make sure when you're going for the exam, you're fully prepared for the exam and you know what you're doing during the exam. One other tip that I would like everyone here to remember is that when you're going for this exam, you're going as a doctor. You're not a student anymore. There is no more things that you can learn during the exam. You have to behave like you are the doctor and who is seeing a real life patient. This would help you in staying in your role. Mentally, it will be easier for you to accept or to process information. But if you go into this exam thinking like a student, you're gonna struggle there. It's a high stress exam. There is someone who is either a physician or a physician examiner or a non-physician examiner who is monitoring you. They are in real life. They're sitting right next to you, um, observing everything. And in those situations, most people get anxious. You can get nervous. Therefore, having practiced the stations or the cases or patient interactions and thinking like a doctor would help you. But if you go in with partial practice and thinking like a student, you're gonna feel the presence of the examiner, even though they're not interrupting you. Make sure for the exam you feel or you get into the feel of a professional doctor or a doctor entering a hospital or a clinic and seeing their own patients instead of just taking an exam. Now, how this exam works or what does it test? So the framework of NAC OSCE is that it checks 7 of your core competencies: your history taking, your physical assessments or physical examination techniques, your organization during doing the history and physical, professionalism, your communication skills, and your management and reasoning or clinical reasoning. Now, history taking, you have to be organized for history taking. If you are jumping back and forth, you're going to miss information. That's why they want you to be to the point, relevant to the symptom or to the patient presentation, and empathetic during doing so. Physical examination, same. If you're going to jump from listening to the or auscultating the sounds of the heart to doing a neuromuscular exam, you're going to struggle. So make sure you are organized, you know what to do and what order. If you are jumping back and forth, you're going to miss key details, and this is going to affect your score. Professionalism, they want to make sure you are ethical, you are not saying or using uh, statements that can be felt as offensive or they can be perceived as offensive. You are using a neutral professional language. You are using, if someone comes, or cultural sensitivity, or you're sensitive to the patient's cultural, sexual preferences or pronouns, etc., and not drawing conclusions without reaching a definitive diagnosis. Now, like I said already, each station is 11 minutes. You can get a station with history taking for 11 minutes and then counseling patient, history plus physical plus counseling, um, history plus physical, physical counseling. It can be any format of the exam. Now, how you manage your time, you can use this quick flow sheet to manage your time better. Divide it into 4 phases. The first phase would be your reading or your preparation. 2 minutes between stations, you will get the time to read the instructions for yourself. In these 2 minutes, review the instructions, look at patient's vitals. Are there any vitals available? If vitals are given, make sure you point out or you underline the abnormal ones. For the vital signs, or for example, especially blood pressure, heart rate, these things, use the latest data. If the blood pressure is given, use the latest guideline, which says 130 or 80 is considered now high blood pressure or hypertension, etc. Don't stick to old guidelines or old readings. That's going to cost you points if you do that. And make sure you take a note of the required tasks. You have pen and paper. They will give you a pencil and a notebook. Write down patient's symptom that you're going to explore, and on the side, write down their vitals. If any is abnormal, underline it for yourself. If you have it underlined, you're going to notice it even during interaction with the patient. When you're looking at your notes, you're going to notice that there is a line under something, and then you remember that you did that line because it was abnormal. And make sure you write the tasks required from you on the paper that you're going to use as a guide for yourself. And what I personally did for myself was write symptom. Let's say patient is here for headache. And then I would write down my structure or the structure I use for headache. Like, let's say I'm using OCD, PQR, STUV. I would write down O, C, D, P, Q, R, S, T, U, V, A, etc. And then I would give it small arrows. These were done in the 2 minutes. It was easy to do in those 2 minutes, but if I hadn't, I would have struggled inside. Now, in most encounters, when you enter, you get 11 minutes. From the 11 minutes, usually 8 minutes are for the patient and 3 minutes are for the examiner if the examiner has something to add. So it says 9 minutes here, but it's wrong. It's 8 minutes. Usually they will give you 8 minutes. In these 8 minutes, you have to take history or interact with the standardized patient and do a physical exam. And in the final 3 minutes, if the examiner has some questions, they're going to ask you questions. Now, during the encounter, what happens is that they're going to give you a warning at the 8 minute mark, not at the 9 minute with 3 minutes remaining. Now, this signal would be your indication to wrap up your encounter because you have 3 minutes left. If the station involves interaction with the examiner, that means you can no longer talk to the patient, switch to the examiner, wait for them to ask you a question, or hand you some lab work or data or vitals or anything that they may bring with them. That's your time to then interact with the examiner. You can no longer interact with your patient or the standardized patient, sorry. And once you are done with the 11 minutes, you leave the room and then you have 2 minutes to move to the next station. In those 2 minutes, again, repeat the same thing, write the presentation. What is the patient coming for? What are your tasks? And is there any abnormal lab or vitals data that you can write down with yourself? The vitals, the lab data that are on the instruction board, they will also give it to you during the station. But it's better to have it written down with yourself, especially if you write it in your own writing and underline the abnormal one, you're going to automatically remember that. Now, history taking. So NAC OSCE history taking is extremely focused. They want you to completely take history of a patient in 4 to 8 minutes. That's why you have to be very focused. You avoid questions that are irrelevant. You avoid things that can not yield anything positive. However, if patient mentions something like a symptom that is bothering them or stressor in their life or something sad about their life, make sure you follow it up appropriately before moving, because if you keep pushing through these questioning when patient is telling you that they're feeling overwhelmed, it means that you're just following a script. You're not interacting with, to you, it's just following a script and you're interacting with a robot, not with a human. So if there is something that comes up between your history taking, follow it up, show empathy, show that you care about the patient, and let the patient know that you are there to listen and to help them. Now, always in the station, when you're taking history, you would have to do these things. Start with an open-ended question. But remember, when you're opening, before you open, you should have already introduced yourself, which is your introduction, taken patient's consent for the interview or the physical examination that you're going to do. Ask the patient if they're comfortable right now to continue, and handed your examination card to the examiner plus sanitized hands, etc. These are some of the basics before you open up the encounter. Opening up the encounter, you can use how may I help you, what's been bothering you, what seems to be the issue that brought you in, what is concerning you. Any opening statement that you prefer, you can use it. Once the patient gives you their chief complaint or the problem or the principal issue that they're facing, characterize it. You can use any structure like OPQRST, old cards, OCD, PQRST, UV, etc. Any structure that you are familiar with and you prefer using it, use that, characterize it, and move on to the review of system. Relevant review of system, only ask questions that are relevant to the chief complaint. Now, if someone is coming with shortness of breath, you don't need to ask them about uh, peeing or pooping, etc. You can just say any issues with your bowel or bladder quickly. That would cover both. Uh, Normally, they won't reveal anything, but if they do, then you may follow up. And remember, before you summarize or something, ask about the patient's feelings about it. What does the patient feel about what is going on, um, or how they feel about their condition? What is their understanding of the condition or idea of the condition? How is it affecting their function? And what are their expectations from the visit? This will help you in narrowing down your counseling that you may need to do in some stations. For example, some patients say, I just want to know what's wrong. In that case, your counseling will be focused more on telling the patient about the condition that they're presenting with. And as always, before you move on to the examiner or before you close the history taking part, summarize what you have heard to make sure it is accurate and you're not missing any detail. Best way to do it is to briefly mention to the patient, for example, you came in because you're having chest pain for the past few weeks and now it's concerning you. There is no fever, weight loss, etc. And then once you mention the positives and negatives, you would say, is there anything that I may be missing? Sometimes the standardized patient would add something, or they would say, no, that's all the information. All right, now, once you're done with the history taking, some stations would require you to do physical exam. Now, physical exam, this is to make sure that you can elicit pertinent or relevant positives and negatives without causing discomfort or causing minimum discomfort to the patient. This is also a basic clinical competence physicians should have. Before you touch the patient, sanitize your hand and explain to the patient what you're going to do. For example, I'm doing abdominal exam. I would tell the patient, I'm going to check or I'm going to examine your abdomen, which is the belly area. I'm going to visibly look for any abnormalities, feel with my fingers, listen to your bowel sounds, and tap on your abdomen. Is that okay with you? This will cover all my four um, physical maneuvers that I'm going to do, which is the inspection, auscultation, percussion, and palpation for abdomen. This is the pattern that we use. Once you do that, you would sanitize your hands before you touch the patient. For example, and keep the examination, focused. For example, if you're doing a chest exam, you don't need to do abdominal palpation unless you feel like palpating the liver is going to cause the hepatojugular reflex and you're going to get a positive finding. Make sure your technique is professional. Patient's right side, verbalize maneuvers as you are performing them. I'm going to listen to your bowel sounds. I'm going to do this. I'm going to do that. Draping, make sure the patient is covered properly. Do not overexpose or underexpose. If you're exposing less area than you need to, that is considered incompetent because you're going to miss findings. If you're exposing more area than you need to, that is inappropriate. That goes against patients' rights and ethics. Once you're done with your physical exam, make sure that you're able to match that with your vitals. If your vitals say that the patient's blood pressure is 89/60 or 89/50, and you find that patient has diffuse abdominal tenderness, this should make you think of GI bleed or splenic rupture, something like that, which would cause acute abdominal findings plus shock. Make sure you verbalize your concerns to the examiner once you have something. If you are in a situation where you think this patient is having STEMI or acute coronary syndrome, make sure you verbalize, I'm going to activate code STEMI, code stroke, code this, and code that, so that the examiner knows you know what the hospital procedures are. Now, communication, this is extremely important for doctors. if you have ever been in a situation where you're the patient, you would know how every small word that the doctor says or the physician says is can become hurtful if it's not worded correctly. As doctors, you would sometimes be required to tell patient that they're going to die, but how you do it is going to make it this news digestible or make this news less hurtful for them. They are going to still have reaction to it, but it wouldn't be as severe as if you just go and tell them you're dying next week. Now, if you are a doctor, make sure you have active listening, you have statements for empathy. If patient says it's really painful, make sure you acknowledge their pain and you show empathy towards them, and make sure that you have a variety of sentences. I'm sorry to hear about it. It must be hard. It must be causing you discomfort. That sounds harsh. That sounds hard. That sounds terrible. I'm so sorry. Any of these, we have Dr. Sneha who does the OET classes. She can give you a list of statements that you can use. Make sure that they match the patient's uh, uh, statement. If a patient says that their father died and you're saying, I'm so sorry for your pain, it's right, but it's not appropriate. Better way would be to say, I'm sorry to hear about your loss. I'm sorry to hear about your dad, etc. So make sure that you adjust these statements to what the patient is saying and make the conversation engaging, interactive, instead of monotonic robot-like conversation with ChatGPT. When you tell it something terrible happened, it will say, I'm sorry to hear that this happened. Do you want a friend or something like that? That's robotic. Don't do that. Make the end conversation adjusted to the patient. And most important thing is to avoid jargon. Jargon is anything that you can say, any technical word. For example, if someone is an IT professional and they keep using difficult IT words, it's jargon. If someone is a journalist and they use journalistic terms, that's a jargon for them. So the idea behind communicating with a patient is that patient does not know medical terms. Patient knows simple terms. For you, it is, let's say it's pneumonia. For them, it's infection of the lung. So make sure that you are using simpler layman terms instead of medical fancy words that we use. Oh, it is the distal radial artery that's impacted. No, just say it is the artery in the rest area that has been impacted. So make sure you simplify it for the patient. Think of patients like you're communicating with someone who has zero medical knowledge. Some patients will use these medical terms. It's good to hear them, listen to them, avoid repeating what they're saying. The medical terms that they're saying, still use simpler terms. If they're using medical jargons, avoid using it yourself. Sometimes it can become our natural instinct to kind of open up with a patient who is speaking medical terms and use all the medical terms. But again, it is using jargons which patients would not understand. You're going to struggle. You would have to repeat yourself again and again for it. If you tell a patient they have encephalitis, now, or family members, since most patients with encephalitis may be confused. So the patient's family member may have noticed or may have told you that they're worried about meningitis, which they saw on Google, but they may not know what is encephalitis. Then you would have to repeat, oh, it is the inflammation of the brain usually caused by viral infections. Instead of that, just say your patient, we suspect they may have something we call encephalitis, which is an inflammation of the brain. This is, you are using that term, but you are simplifying it without having the patient to repeat or ask you what that means. If you can avoid at all, avoid it. But in some cases, if for example, particularly when you're giving the patient the diagnosis, use the medical term for it and then explain what it is in a sentence. For medical diagnoses, we usually have to use the terms themselves. But if you can avoid it, for example, instead of pneumonia, if you can say it's an infection of the lung directly, that's fine, or that's better, because patients would understand infection in the lung better than a pneumonia. Now, one competency or one core competency that they check in your exam is your clinical reasoning and management. Clinical reasoning, they want to see how you approach a difficult or complex clinical presentation. And in management, they want to make sure that you are a safe physician and you're not doing something that can end up harming the patient. For clinical reasoning, they're going to ask you for differentials. Now, you would have a patient with headache and their history would be 100% pointing towards migraine headaches. Again, if you say my patient has migraine headaches because of unilateral uh, pain that is also associated with photophobia and worse with noise and gets better in a dark, quiet environment, I'm strongly suspecting migraine headaches. However, I will keep other differentials like cluster headaches, this and that in my differential list to make sure that we do not miss anything. This is the way to give your differentials to the physician examiner when they ask you what is your diagnosis or what is the differential diagnosis for this patient. If you just say patient has migraines, remember migraine is a diagnosis that you can keep after you rule out other organic causes. So migraine cannot be your first 100% diagnosis. You have to make sure patient doesn't have other organic causes first. If they ask you what is your next step, so they want you to go logically and chronologically, go one by one. So my patient has migraine headaches. They do not have any neurological symptoms. Their physical exam is benign. There are no neuro concerns, no red flag symptoms at this moment. I'm strongly positive patient does not have organic cause, and I would avoid testing for now. Give patients some medication or most cases somatriptan to help with the migraine attacks. If the headaches get worse, the patient starts to show focal neurological deficits. In that case, we would get a CT scan of the head and do some basic labs. For now, patient does not need anything of that sort. All right. This should be stepwise. If you say, I'm going to do head CT for the patient and doesn't need anything, and then you say, oh, I'm also going to do lab work for him. It's okay. We are humans. We can sometimes mix it up, but in exam or when you're a doctor, you're expected to be in order or chronological. Just go stepwise. Think of it. Take your time. If you have to think for 30 seconds, I would rather use think and respond more logically than hurry a response. That is wrong. Now, for management, they want you to make sure that you prescribe to the patient what is needed and you stop them from doing what can make their symptoms or their condition worse. For patients with migraines, you would usually tell them to not drink alcohol. This is lifestyle, right? So lifestyle changes, medications, and then so stepwise. First would always be lifestyle changes, then medications, and then surgical treatments if available. And for your management, you have to have safety netting for the patient. If patient comes with red flags or patient comes and there is a red flag in their living situation, you have to address that. For example, patient with fall, and you're not addressing their living environment. They have dim lights, they have carpets or rugs running laid out. These are hazards. They can fall again. So make sure that you're addressing those. And finally, make sure that you listen to the patient. Ask them what they want. Share decision making. You present the patient with options. So these are migraine headaches. We recommend that you avoid alcohol. You can use Tylenol for pain management. You can use somatriptan during attacks. and we can give you propranolol for chronic management or chronic prevention. What do you want to do? Do you want to try lifestyle changes first and then see if they help? Or do you want to try Tylenol first? Or do you want to do simnotriptyline? Or do you want to take propranolol to prevent the attacks from happening? Let them decide. Give them the option. They are going to decide. This is the uh, management things. Some of the common stations that you may face in your exam. In internal medicine, chest pain, shortness of breath, diabetes, joint pain. These are some of the things that you may face. In surgery, fever, post-operative fever, acute abdomen, preoperative wound care, pediatrics, fever, rashes, asthma, developmental milestones, childhood nutrition, OBGYN, prenatal care, vaginal bleeding, contraception, and pelvic exams, etc. Now, in exam, you're not going to be doing pelvic exam, rectal exam, and breast exam. These are not allowed for you, okay? So if something or a station requires you to do rectal exam, you verbalize it. Examiner will say skip, negative, or positive, okay? Now, how you manage your time? It's very important that you're able to manage your time. So when you're practicing, make sure that you're practicing history taking for 8 minutes and then 3 to 4 minutes of differential diagnosis or however you want to spend those time. Counseling, however you want to do. But 8 minutes, you should be able to take a full, comprehensive, but focused history. You don't need irrelevant information. Uh, if it is a full station with history, physical, and counseling, so make sure that you do forget the 4-3-2. It's going to finish it in 9 minutes instead of 11. So you have 4, 4, and 3. 4 minutes history, 4 for physical exam, and in the last 3 minutes, counseling. Transitioning. Now, if you're taking history, during history taking, when you're transitioning from review of systems to past medical history, make sure you say, I'm going to ask you about your health in general or your past medical history, if that's okay with you. If you're moving to family history, let the patient know you're going to ask about family history. If you're going to ask about social history, make sure you ask that you're going to, or you verbalize to the patient that you're asking about family history, social history, and if they're okay to share. And when you're doing your physical examination, they want you to verbalize your findings. For example, you palpate the abdomen and abdomen is acutely tender everywhere. They want you to say, I'm able to elicit tenderness in all the quadrants of the abdomen. And then once you say the finding, make sure that you connect it to your patient. And and this generalized tenderness is making me concerned about a possible bleed or a possible spleen injury, etc. Now, when you're reading your instructions between two stations, read them once slowly and try to understand what they're asking you. Don't try to rush through them. You have 2 minutes. They're enough to read like a whole paragraph and understand it. If you do not understand what's saying the first time, read it again. If you have to wait outside 30 seconds longer than the 2 minutes, please do that. Don't enter without knowing what you're going to do inside the station. If you enter and you don't know what you're doing, you're going to be all over the place, and this is going to negatively impact your overall score. Make sure you take your time to notice what you're going to do inside the station or to know what you're going to do inside the station. Handling interruptions. Sometimes if the examiner asks a question, which is rare, I haven't heard anyone say that the examiner asked them a question during their time with the patient. So it's unlikely that this happens, but if they do ask you, just stop and address it. Keep it concise and direct. You don't need to over explain or overstate something. If they say, what does this finding tell you? Just let them know, turn towards them and tell them it may be a sign that the patient has acute abdomen or acute bleed inside the abdomen. Now, these are some of the common mistakes that IMGs make. These will make your score crash. They're gonna affect your score. Now, first mistake is the robotic approach. Um, if you are asking patient question after question after question without acknowledging their feelings, their perceptions of the symptom, etc., it means that you're following a checklist and you're not trying to get a conversation with the patient or talk to the patient. If you're ignoring patient clues, you're going to miss key details, and you will have a patient who has depression and you diagnose them with uh, something different. So make sure that you're not ignoring patient clues. Patient may say, I have been feeling sad, I've been feeling disconnected, something like that. They may say, um, my husband or my partner hits me, something. So if something like that comes, make sure you follow that up. Sometimes they will give you hooks or these symptoms or these minor details in conversation, in the natural flow of the conversation. So make sure you pick up on those and you follow them up. If you have incomplete vitals, um, or if you have vitals that are abnormal, make sure that you bring it up and you do not miss it. For example, if patient is coming with headache and they have a high blood pressure and you say they have a primary headache, this is a red flag and it's a safety error. You're going to lose a lot of points for this. So if someone has an abnormal vital and they have something in their history that matches that vitals, make sure you connect them and don't miss that. High blood pressure, fever, um, low heart rate, high heart rate, tachycardia, bradycardia, tachypnea, bradypnea, any of these things. For example, patient with acute onset shortness of breath also has tachypnea and tachycardia. This could be pulmonary embolism. So make sure that you connect those vitals with the patient's symptoms. And once you're done with the questioning or the history taking, make sure that you have your summary. So get used to a script, make a script, adjust it to your patient, and make sure that the patients understand what you obtain from them and it's accurate, and ask them if there is anything they would like to add. For example, you came in with a headache. It has happened before. It's on one side. It gets better in a dark, quiet environment, gets worse when you're outdoors in a bright, noisy area, and sometimes alcohol triggers it. I believe you have what we call migraine headaches. It's more common in women in their 30s, etc. And these are some of the ways that you can summarize your findings. Is there anything I may be missing? At the end, please add this sentence. This one sentence is going to save you a lot of headaches. Sometimes patient or the standardized patient, they will give you another positive clue. Finally, over testing and under testing. Do not do over testing and do not under test. If patient requires an MRI, don't say I'm going to do an X-ray. Do an MRI. I'm going to give you an example for back pain. If someone comes with back pain that started after lifting something heavy, it's sharp in nature and it's not radiating down, this is likely a musculoskeletal pain. You don't need X-ray, you do not need MRI, you do not need any further testing. But if the same patient had this pain after a heavy lift or after doing something intense, and the pain is going down to the legs, and they're having numbness and tingling, erectile dysfunction, or urine retention or incontinence. These are red flags for nerve or for cauda equina or conus medullaris. Any of those, herniation is a possibility here. Make sure you order the MRI. Do not say I'm going to do a chest, a back lumbosacral X-ray for this patient, because the X-ray is going to miss a lot of things. Just say I'm going to do a stat MRI for this patient to make sure there is no nerve impingement or there is no surgical emergencies. Cauda equina is one possibility. Another would be conus medullaris. We are going to do stations that are going to clarify how to differentiate them. But if there is red flags present, make sure you do the test that is the most accurate and the gold standard. Do not say, I'm going to do chest X-ray for, sorry, a lumbosacral X-ray for this patient? No, do MRI. X-ray would be okay to do if patient was not acute. If patient has numbness, urine incontinence, urine retention, any of these symptoms, it means that there is nerve impingement going on. We need to see what is causing that impingement, and we have to address it quickly before the patient permanently has uh, loss of this function. Therefore, do not say I'm going to do just an X-ray. X-ray is going to show you what in the lower back. The vertebrae are not aligned. Now, would it show you that if they are impinging on the nerve? Unlikely, because you won't see the nerves on X-rays. You would just see the bones, right? So make sure you do MRI for someone who has these red flags. Now, if you're studying for the NAC OSCE exam, so prioritize high yield topics, but be ready for those very tiny, really subtle symptoms. Sometimes they will give you a very awkward symptom that you may not have faced in your real life clinic, or so make sure that you keep those in mind that they can show up on your exam, but practice these high yield topics for cardiology, anginas, chest pains. I'm going to say chest pain and heart failure. These are the things that you have to know and be able to understand how they present. Arrhythmia is another topic that's very important in ACLS or cardiac life support. It's an emergency, specifically if it is a VTAC or VFib. So in those cases, make sure that you know what the next steps would be. Respiratory, you can get a patient with COPD exacerbation, simple chest infection, or a community-acquired pneumonia, or you can get someone who has an embolism. Endocrine, type 2 diabetes is very important. Hypothyroidism, hyperthyroidism, these are two of the conditions of the thyroid that may be tested, or they may give you a patient with a cold nodule or a hot nodule of the thyroid. Musculoskeletal, you're going to get stations on arthritis, lower back pains, knee pain, elbow pain, chest pain, sorry, not chest pain, shoulder pain, ankle pain, any of acute pains, musculoskeletal pains, or something chronic like osteoarthritis, rheumatoid arthritis. In pediatrics, failure to thrive, this is something that may show up. These are high yield topics. Otitis media or otitis in general, this is a high yield topic. Fever of unknown origin or fever in general is a high yield topic. If they're going to give you a fever, it's likely that the patient is not present. It is just the parent that you're taking history from. So make sure if you're asking questions of fever, that what could be causing fever in a child, right? Is the child tugging on the air? Are they passing foul smelling urine? Are they passing more urine than usual? Are they constipated? Are they having diarrhea? Things like that. In psychiatry, depression, substance use, psychosis. Psychosis is really hard to imitate in a real life exam. Therefore, it's unlikely to come on your exam, but they may give you a patient who had a psychotic episode, and now you have to talk to them after their episode. OBGYN, ectopic pregnancy, menopause, menopausal symptoms, management of those symptoms, etc. These are some of the topics that are very high yield topics. These are some of the resources that you can use. Medical Council Canada's resources. These are the most reliable resources. If you use these and you say something from these, they're not going to deduct your points, even if it is right now not considered best practice because you use their resources. So make sure you look at the resources that they list as their preferred one. Geeky Medics, they have really good videos on how to approach different symptoms. You can watch them for free. They also have good physical examination video. Toronto Notes, it's a very comprehensive book. It's long, uses the references, but one problem with this is that Toronto Notes is for written by PG year 1 students. So it's going to have things that you don't need. It's beyond your scope. So if you want to use it, it's a really good resource. It has a lot of information that you need and some extra information that you don't need for your level. Join a study group. You have a WhatsApp group. ask people that can join you during your preferred time and the time that works for them. Practice together, 3 to 4 people, 2 people, 3 people, 4 people. If you can get a group of four, one would be the physician, the other is the student, and then one person is taking notes to make sure that they notice if the person doing the history is making any mistakes. And practice courses like this one, these are some of the things that you should do for your exam. And finally, when you're in your exam, you are the physician, you are not a student anymore. And this is walkthrough station, 9 minute or 11 minute station. First 2 minutes are for your when you're outside the door or at the door waiting to enter the station, you're going to read the instructions. And then once you go in there for the first 1 to 2 minutes, make sure that you talk to the patient, introduce yourself, sanitize your hands. Sorry, when you enter, greet, verbalize that I'm going to sanitize or sanitize your hands, and then give your examiner your card and then sit down. But before sitting down, make sure you ask if you can take a seat and then start talking to the patient by introducing yourself and then asking about what's their problem. Physical exam, 3 to 4 minutes. Usually, if it is something that you're very good with, for example, I have worked a lot in chest medicine or thoracic. For me, lung sounds are extremely easy to detect. Any abnormal sound, I will pick it up in a few seconds. So I can finish a chest exam in 2 minutes. But if I was to do a muscle or a joint exam, then it would take me longer than that. Make sure if you're in a station where you have an uncomfortable physical examination to do, you're leaving yourself enough time to be able to do it uh, professionally and do not miss things. And finally, closing, explain to the patient what you're going to do next as a summary. Some tips for the exam. In the exam, they will give you a set of guidelines to follow. You are to wear formal dress. For men, it's usually suit or without the coat, just the shirt and pants, and then no ties. On top of that, you're going to wear your white coat and have your on stethoscope. Everything else that you need would be in the exam. And mindset, think like a doctor. Each station is a new patient, new start. You have 2 stations as a cushion. So if you perform badly in one station, just do not think you failed the exam. Think like it's okay. It's possibly my pilot station. It would not affect my score. Go to the next station. Logistics, arrive early, check the site or the layout of the site and check-in procedure, etc. In cases where you're not sure, just verbalize logically and say what you're looking for. If it is not matching what the finding is, it is okay. Sometimes what we find and what we think may not match, but again, make sure that you are logical about it. Don't say that patient's tenderness in one quadrant is an acute abdomen or peritonitis. Sometimes a localized peritonitis may have a localized tenderness, but patients who come with peritonitis, they would have generalized tenderness. So don't say things that are inaccurate. If you don't know what's going on, just say that I'm looking for this. There is this positive finding. I'm going to continue my examination to be able to connect it to this patient. And again, be kind to yourself. This exam is challenging. No one is perfect. Just make sure you are doing the exam as a physician who is safe and empathetic to the patient. Now, these are some of the takeaways from today's session. take focused history, targeted physical exam, and be empathetic with your communications. These are the three things that are going to make your score go high. Practice with your group, focus on your timing. Make sure that when you're practicing, you are timing yourself. Do not practice blindly without timing yourself. And finally, you're a doctor. You already know all this materials. You already know, and you would already manage a patient with chest pain to your home country where you are eligible to practice. Patient with chest infection, you know how to manage them. This exam is just to demonstrate to the examiners that you are safe to practice in Canada. And if you have any questions, you can ask them now. Sorry, I will give you time to ask questions. So some of the expectations for this class are join on time. If you're interacting with each other, normally that will be minimal. But if you are interacting with each other, please be respectful. If you're addressing each other disrespectfully, I'm going to call you out. I do not accept it. I have done it already. I will do it again. I don't have any issue with calling out people if they are being disrespectful. Our standardized patient, who is Dr. Sneha, please think of her as your instructor. She's going to be guiding you over some things like communication, particularly. She is the one who manages the OET class. And when you're coming to the class, look at the curriculum. What does it say? Is it week 1? Is it acute coronary syndrome, or is it heart failure? And whose class you are attending. So if it's my class, look at what topic I'm doing on that day. Read their topic from Toronto Notes, first aid, anything that you use, any book that you use. If you are comfortable, read it from Harrison's textbook of internal medicine, which is like an 8,000 page book. That's the most comprehensive medicine book that you will find. Read it from that if you have the time and energy to do so. If not, use Toronto Notes, use first aid, anything that you think is going to give you enough information to be able to participate in the class and be ready. Proactive participation is required. I want everyone who is present in the class to volunteer for the station. This makes it easy for me to figure out what the weaknesses are, where I can help you better. If you're not participating and you're just listening, I won't even know that you exist in the class. That's the issue we had with our previous session, our previous batch. Participation was low and it was discouraging for us too. So make sure if there is a case that you are not comfortable with, I want you to take that challenge. Trust your instincts, yourself. You are a doctor in your home country. You can practice there. So what is stopping you from just interacting with a patient who you would see in your clinic at your home country, right? Volunteer to take cases. Participation from everyone is required. And taking cases, we would see how it goes. We want you to volunteer. If not, then I'm going to ask you to do a station. When doing station, and if it's possible, keep camera on while doing the interaction so I can see how you're doing with your gestures, your nonverbal communications. If it's not a possibility for any reason, it's okay to keep it off. Just keep the microphone on during the whole station. Don't turn it off and on while you're talking to the standardized patient. And when you're not doing a station, please keep your microphone off. If you're not doing stations, camera is optional. If you want to keep it on, I'm okay with that. Otherwise, keep it off. I don't really worry about it. And finally, clarify information before jumping to conclusions. If I say something that you think may not be accurate, please clarify it with me. Sometimes I may not word things 100%. So if that does happen, make sure that you clarify with me before you jump to any conclusion or get information that is wrong. With that, this was the basics of what we're going to be doing in the NAC OSCE exam preparation.